So it's 5 o'clock on my watch, so we can start the session, sir. Dr. Siddharth, can we start? So you need to unmute your mic, sir.
Yeah, hi.
Dr. Manoj, are you there? So Dr. Manoj is there joining, sir. So let him just give the introduction and then you can start the session, sir.
Yeah, that's what I'm waiting. Yeah.
So you can start the session, sir, Dr. Manoj.
Yeah.
Dr. Manoj? Hello? Dr. Manoj, can you please start the session? Hello? Dr. Siddharth, can you hear me?
Yeah, I can hear you.
Dr. Manoj?
Hello.
Yes, sir. You just need to start the session, sir. So,
Actually, there are a lot of calls coming on this, so in between I'm getting, let me. Can you give me 1 minute? I will join through my my laptop.
yes, sir. No
Just
issue.
give me 1
No
second.
issue.
A lot of disturbance on this. So
we
can we
can-
start now?
Yes, sir. Yes, sir.
So good evening, everyone. And today we are going to have a very interesting session, and that is feeding in ICU. That is a topic which is most often thought to be very simple thing, but if you see in our day-to-day practice, it is really the nurses and the paramedics, they usually faced with a lot of problems and challenges. And as you all know, that the overall outcome of the ICU patient is so very dependent on this enteral feeding. So on this topic, we are going to be enlightened by an eminent speaker, that is Dr. Siddharth Verma. He is an Chief Intensivist at Care and Cure Super Specialty Hospital at Bilaspur. And of doing, can we have his introductory slide? Neil, do you have his introductory slides for?
No, sir, this is all. Yeah.
Okay, so after doing his, I know him very well, so I thought I'll introduce him more precisely. But anyway, he has been my colleague, my secretary in our and chair of this ICCM Bilaspur chapter. We have been doing a lot of academic activities in this part of area for medical professionals as well as for the nursing. And he has been always very inclined in the academics. He has done his graduation and post-graduation from Raipur Medical College. After that, he did his training in critical care from Bombay Hospital, And now over to you, Siddharth, for your lecture.
Thank you so much, sir, for your kind introduction. So today we'll be discussing the topic that is feeding in ICU. As Dr. Manoj Rai has said, that this is a very important topic, and quite often it has not been given so much attention. But the outcome in the critical care is very much dependent on this part as well as the general nursing care. So in this topic, we'll be discussing most of the types of, rather than discussing types of nutrition, we'll be discussing techniques and methods of the feeding in ICU. We'll not be going much into the nutrition part, but we'll be definitely discussing the feeding patterns and things like that in our ICU. So yeah. So why it is important to feed correctly in sick ICU patients? As we all know that these patients, they have different energy demands, and they are mostly hypercatabolic and catabolic or hypercatabolic patients. These are they require different energy, and they have different energy demands in the ICU. They have got some of them, some of these patients are chronically ill patient. They have got pre-existing malnutrition, and these patients, when you start feeding, you face refeeding syndrome kind of thing. Then do you have some mechanical challenges when you start feeding in the ICU? The position of the patient, as in the recent times we are suffering from the COVID, and there are so many patients who have been ventilated in prone position, and in these patients feeding is definitely a challenge. And then there is a resource limitation, as we are all are facing that we have surge of COVID patients, and the nurse to patient ratio and the doctor to patient ratio is totally not maintained. So we have got resource limitations as well in these days. So that's why it is very important to feed these sick ICU patients in a correct manner. So what options we do have? We have either we do enteral nutrition, and we do have a parenteral nutrition. So critically ill patients are mostly at the risk of malnutrition. They have acute and chronic illness, as well as acute on chronic illness, trauma, inflammatory stress related catabolism. Sorry. Stress related catabolism, drug induced adverse effect may reduce the appetite, and they may cause increased nausea and vomiting. And patient management in intensive care unit may also interrupt feeding routines, like you are taking the patients to, for certain procedures, you're taking the patient to CT scan where the patient has to lie flat. So these things may interrupt the routine feeding times. So, and there are methods to deliver nutritional requirements include enteral nutrition, parenteral nutrition, and this may be a combination of enteral as well as parenteral nutrition. So what does it mean by enteral, parenteral, and combined enteral and parenteral nutrition? The term enteral nutrition, first we should understand what is enteral nutrition. It refers to the nutrition administered via GI tract. It may be administered by orally or via tube feeding. So oral feeding, as we all know, the tube feeding is the person has a condition or illness which limits or impairs its oral intake. Enteral nutrition therapy can be administered directly into the gastrointestinal tube as tube feeding. Specialized tube liquid feedings may contain protein, carbohydrates, and fat, vitamins, minerals, and other nutrients as required. And these nutritional products products are formulated to meet individual needs of variety of disease states and condition. Now, what is parenteral nutrition? Parenteral nutrition is basically an intravenous administration of the nutrient directly into the systemic circulation, bypassing the gastrointestinal tract, when the nutrition cannot be met by oral or enteral routes alone, or they are contraindicated by some of the other reason. So if you see in the figure, Uh, these there are there This is parenteral and enteral nutrition. What could be the first? We'll see the parenteral nutrition. They are, as I told you before in the previous slides, the feeding is given intravenously and bypassing the usual digestive tract. The feeding can be through the central vein, or it could be from the peripheral vein. We'll discuss it in detail in the subsequent slides. Then there can be enteral nutrition, where the liquid supplement nutrition has to be taken either by mouth or can be given by a feeding tube. This could be the feeding tube can be in nasal or oral. It can be in that it can terminate into stomach, duodenum, or jejunum. And feeding, there are some feeding tubes which can directly put in through the stomach, which is called a gastrostomy or a peg feeding tube. And there can be a feeding tube which can be placed into the jejunum through a jejunostomy. So these are the, and you see the slides, if you can see in this slide, these are nasogastric, nasoduodenal, nasojejunal tube. Then there is percutaneous antral gastrostomy, balloon gastrostomy, or button gastrostomy. Then they have in jejunal, when the tube ends, the other end of the tube, if it ends in the jejunum, there could be percutaneous and endoscopic jejunostomy, percutaneous radiologic jejunostomy, surgically placed jejunostomy, which has been put intraoperatively, and percutaneous endoscopic gastrojejunostomy. Why it is important to start early enteral nutrition? It should be started as when the patient has put in the trials tube and the patient has been stabilized. The patient has to be started feeding within 48 hours, not more than 48 hours, if oral intake is not possible. It preserves function and the structure of the gastrointestinal tract. It also activates the immune system and modulate metabolic response. It improves survivals. In shock states, it can be delayed till the perfusion of GI tract is restored. Refeeding syndrome, you need to keep this thing in mind. It is common in acute on chronic malnutrition when you start feeding them. And the indication of starting early enteral nutrition is severe trauma, burns, ARDS, major abdominal cancer surgeries. And the contraindication is like loss of bowel anatomical activity, severe splanchnic ischemia due to shock, and generalized peritonitis. Now, feeding techniques in ICU. This is the main topic in our talk. Basically, there are feeding techniques. There are 4 types of techniques. One is the continuous technique. The other is cyclic, intermittent, and bolus techniques. We'll discuss in detail in subsequent slides. So in broadly, continuous feeding involves hourly administration of enteral nutrition over 24 hours, assisted by a feeding pump or a gravity pump or a gravitational method. Cycling feeding involves administration of enteral nutrition over a time period of less than 24 hours, generally assisted by a feeding pump or gravity. Then intermittent feeding, it involves administration of enteral nutrition over 20 to 60 minutes every 4 to 6 hours via pump assist or a gravity assist. The bolus feeding involves administration of enteral nutrition over 4 to 10 minutes period using a syringe pump or a gravity drip. So in practice, pump assisted continuous feeding is generally acceptable for critically ill patients to prevent enteral nutrition related complications. In addition, regarding muscle protein synthesis and GI hormone secretions, intermittent and bolus feeding may be more beneficial than continuous enteral feeding for critically ill patients. And for medically stable patients with feeding tubes terminating in the stomach, bolus feeding is favored with respect to practical factors such as cost, convenience, and patient mobility. We'll discuss it one by one. The continuous feeding, you can in this technique you need to attach it to IV stand, and you give it by the gravitational method and or by a feeding pump. So it is easy. The advantage of this method is it is easy way to determine the tolerance of tube feeding, because you start it very slow and gradually once the patient starts tolerating, you start increasing the amount of the feeding till the desired level of feed has been achieved. Then the gentle, it should be started gentle, and there should be gradual increase. It is basically best tolerated by the patients who have gastroparesis, like diabetes, abdominal surgery, and neurological disorders. The other advantage is you have low maintenance for nursing staff. Not much nursing staff is required to check this for time to time. And it is, but the disadvantage is that it has got burden for the patient who is awake and active, because the patient has to be there all the time attached with this tube. So this is quite uncomfortable with the patient, and there is persistent feeling of fullness as complained by the patient. So these are the disadvantages of continuous feeding. The other comes is the cyclic feeding. Basically, infusion formula is infused in less than 24 hours per day. Like in continuous feeding, it was continuously given for 24 hours. But this, in this cyclic type of feeding, you give a break for say 6 to 8 hours of break, and mostly it has been commonly it has been given for 12 to 16 hours or maximum 18 hours in a day. So basically, in with this type of feeding, you prefer to give the patient feed in the nocturnal time, because the patient is sleeping and you can just start the feeding, and the patient is not very much feeling attached with the device when he is awake. And it has to be given by a mechanical pump or a gravity assisted method. It maximizes the mobility and activity throughout the day, because it is being given mostly in the night time, and it can avoid feeling of fullness before meal time, so that patient can still have their oral feeds if the patient has to be started on the oral feeds. And there is a low maintenance for nursing staff in this. This is also an advantage of this, and the patient. But the issue is the patient is still connected to the extended period of to the infusion pump, and it requires higher feeding rates than continuous feeding rates, because you need to give that much amount of fluid in lesser amount of time. Then comes intermittent feeding. Basically, in this intermittent feeding, you infuse it for 20 to 60 minutes and 3 to 6 times per day. Like an example has been given there. It is like you start at 8 o'clock, in the morning, you give 400 ml, then at 12 o'clock, then again you give 400, and things like that. So this much amount you give for 20 to 60 minutes over a period of time, and it can be given by mechanical and gravity method. But in this, you need to have water flushes to prevent clogging, bacterial growth, and keep the patient hydrated. It avoids the patient to provide tube feeding overnight, and but the patient must be able to tolerate large volume of formula. Patients should not have gastroparesis and GRD. These patients are unfit for these type of feeding techniques. And there is definitely a high maintenance for nursing staff, because nursing staff has to go to the patient in these times and attach, and then once the target has been achieved, you need to disconnect the pump with the patient. Then lastly, this is bolus feeding technique. The bolus feeding mostly closely aligns with the normal feeding patterns. Basically, you infuse 8 to 9 times of feeding in less than 10 minutes, and you don't require feeding pump for this. The catheter syringe tip is used, syringe plunger, and it is mostly gravity method is been used. This I think every nurse is very well versed with this technique. And after you give the feed, you use water flushes to avoid any type of clogging in the tube. And it allows high amount of mobility and activity. Patient need not to be attached to any tube feeding overnight. So, and but the patient must be able to tolerate large volume of formulas, and definitely it is a highly challenging for nursing staff to give every too early to the feed to the patients. Now, enteral nutrition. What could be the interruption between our feeding in our feeding schedules? This could be procedures related to respiratory, radiological, operating room, bedside problems, and feeding related issues. There could be intolerance like elevated gastric residual volume, abdominal distension, intolerance to the feed like vomiting, regurgitation, and diarrhea, and illness related like the patient has GI bleed or the patient is too sick or is in shock state and not able to tolerate the feed. And potentially avoidable things like plant procedure has been done and but not executed immediately after the fasting period. So that can also interrupt our feeding schedules. Now there is an important thing which we need to discuss, that is called gastric residual volume. This is every sister does this. This is a very common practice in our ICU. So basically, what is this? This is the amount of gastric contents found in stomach at a single point of time by using catheter tip syringe and withdrawing the plunger attached to the syringe, which is attached to the rice tube. So basically, their goal is to detect the feeding intolerance and as a result to prevent vomiting, regurgitation, aspiration, and development of aspiration pneumonia. So, there are so many studies that suggest there is a lack of agreement on which on what is the amount in ml which constitutes a significant gastric residual volume. What are the limitations for gastric residual volume monitoring? So basically, there are so many limitations. That why this method is been now not very much been practiced in Western countries. So what are the limitations? That feeding tube diameter, because if you have higher diameter of a feeding tube in the patient, then there are chances of getting high gastric reserve volume. And if you have lower feeding tube diameter, then you have a chances of lesser gastric reserve volume. So this is quite unreliable. How do you measure the gastric reserve volume? Then there is a level of the tube in the stomach. Usually it has been seen when the rice tube has been inserted. These are most on the pyloric side, and when the gastrostomy tube are being inserted for feeding, those are most on the upper side of the stomach. So this could also lead to different amount of aspirations, gastric residual volume in patient when you aspirate before giving other feed. The procedures, then there are several studies that suggest the elimination of gastric residual volume monitoring and is not associated with the risk of aspiration pneumonia and duration of mechanical ventilation, ICU stay, and mortality. It increases improvement and also if you don't measure the gastric residual volume as give feeding as your standard methods, it also increases the improved nutritional delivery to the patients. Then individual techniques can also affect the amount of gastric residual volume. So if you slowly and intermittently aspirate high gastric residual, there could be chance of high gastric residual volume. And when you have fast and when you have fast aspiration, then you have chances of getting low gastric residual volume. Then SPEN and SCCM guidelines and suggest that against the routine monitoring of ICU patients receiving enteral nutrition, you should not monitor gastric residual volume. And if you are routinely measuring gastric residual volume, holding tube feeding for gastric residual volume less than 500 ml should be avoided as long as there is no other sign for feeding intolerance. And you should have your own hospital policy for gastric residual volume. So this is the algorithm which we follow in our ICU as well. And you should start once the patient is admitted into the ICU. You should ask the physician whether feeding can be started, and there should be documented reason for the withhold or delay of the enteral feeding. Like there is a severe general condition like shock. The patient is in a vasopressor. There is high lactate levels. The patient has severe hypoxemia. There is some abdominal pathology waiting for investigations, like the patient has damaged gastrointestinal tract, higher patient has got fistula, or the patient has started on oral diet. So once you have got the permission from the physician to start feeding, then you put a nasogastric tube or other feeding tube in the place, check the position once, and you measure the gastric residual volume. And rest of the thing is mostly related to the gastric residual volume thing, which we have already discussed in the slides. So there should be an individual policy in your ICU how gastric residual volume needs to be considered when you give feeding to next feed to the patients. Now comes to the type of feeding tube. It depends upon how long the patient requires the enteral nutrition. Basically, broadly, we can divide in short-term feeding and as well as long-term feeding. Mostly short-term feeding is like less than 6 weeks, and if the patient has to be on tube feeding for more than 6 weeks, it is called long-term tube feeding. Then you need to understand this nomenclature of this feeding tubes. So when the tube is inserted through the nose, usually the tube name starts with naso, and the when tube is and where it ends, it called if the tube at the other end of the tube ends in stomach, it is called nasogastric. Same way, if it is being given through the mouth and it ends in the stomach, then it is orogastric tube. Same way, if it's inserted from the nose and ends into the duodenum, then it is nasoduodenal tube. And if it starts inserted from the nose and it ends into the jejunum, then it is nasojejunal tube. And if it's inserted through the mouth and ends into the duodenum, it is oroduodenal or oroduodenal tube if it ends into the jejunum. So this is the nasogastric and the orogastric tube. These are the most common method of giving tube feeding to the patients, and it aligns with the normal digestive process, and it is easily can be placed at the bedside. It reduces the delay of the feeding and can be used as a trial tube. So, and these the next four, the nasoduodenal, nasojejunal, oroduodenal, and orojejunal, these are more difficult to place, and it requires highly trained staff member. It requires endoscopic and fluoroscopic. The least common thing is being used is nasoduodenal and oroduodenal tube. So this is the just figure of simple of an RT tube and the things and the method in which we give feeding to these patients through RT feed. This is via feeding pump. There is an enteral feeding container. And then the enteral feeding pump. It has been attached to the rise tube, and in this way, the patient needs to be given the continuous feeding through the pump. Then comes the gastrostomy tube. This is the just anatomy. You can have a look on this. This is an abdominal wall. This is the PEG tube in which it has been inserted. And this is the stomach where the balloon has been inflated, and through this tube in which we can give the feed to the patient. So this is the actual picture where looks like where the percutaneous percutaneous or endoscopic gastrostomy tube has been placed. So what are the advantages of percutaneous or PEG feeding? This is basically when you want to give it for a long time. It definitely the quality improvement. It improves the quality of life. It can be hidden from the view. The disadvantage is more invasive than a short-term feeding tube, and it has got a risk of infection and skin breakdown. So You should wash your hands, assess the abdomen for distension. The patient should be head up or to the 30-degree. If it has been, if PEG tube is being used, measure gastric residual volume every 4 hours. And if the residual volume is more than 500 ml or as decided by in your ICU protocol, hold it for 1 hour, recheck, and if it is still remains high, you need to discuss it with your doctor. If using a PEG tube, reinstall and reinstall the residual. If the residual volume is coming high, then you need to put back all the feed back to the stomach. Then you should prime the tube, then connect the tubing to the client, the set rate, and the start the feeding pump. Then in PEG feeding, when you give by bolus techniques, initial methods are like same. Insert a 60 ml syringe, then you need to insert a 60 ml syringe to the port and pour the feeding product into the syringe. Add formula to drain by gravity, then more formula until the desired amount is infused. Flush it by 50 ml of water and recap the tube. So what could be the complications of feeding? There could be aspirations of gastric secretions. Like you need, in that condition, you need to discontinue the feeding immediately and perform tracheal suction or aspirate of the aspirated contents. If possible, notify your doctor. Prophylactic antibiotics and chest physiotherapy needs to be ordered. Check nasogastric tube placement before feeding and prevent complications. Then you have tube obstruction. Flush the tube with warm water. Flush the tube with 50 ml of water after each feeding to remove excess sticky formula which can clog the tube. When possible, use liquid formulas for medication, otherwise crush well. Oral, nasal, and pharyngeal irritation or necrosis. How do you manage this? Perform frequent oral hygiene using mouthwash or sponge tip swabs. Use petroleum or water-based lubricant on cracked lips and change the position of the tube. Then comes vomiting, bloating, and diarrhea. This we'll discuss separately in the other slide. How do you manage diarrhea in these patients? Basically, you reduce the flow rate. If you are doing boluses, place the syringe lower to decrease the rate of the bolus. Warm the formula to prevent GI stress. For 30 minutes after the feeding, position the patient in his right side with the head elevated to facilitate gastric emptying, and notify the doctor if the patient still has problem. Then there could be constipation. To provide abdominal additional fluids. If you have constipation, then you provide additional fluid if the patient cannot tolerate them. Administered a bulk forming laxative with doctor's approval, and you may have hyperglycemia and you need to monitor the blood glucose level, notify the doctor of elevated levels of sugar, and administer insulin if it has been ordered. So this is a very important thing when you start enteral nutrition. There's a diarrhea. Many of the times we encounter this problem. This is mostly related to the osmolarity of the feed which we are giving, the feeding rate which we are giving. When you give feeding in a very fast rate, then you may encounter the diarrhea thing. And osmolarity, when you give a fluid, when you give a feed which has got very high osmolar value, then it may also cause diarrhea. And if the patient standard versus pre-digested, in a standard feeding method, in a standard feed, basically the osmolarity of the feed is very high as compared to the pre-digested thing. So this could also make a difference. Then the lactose content of the feed and the fiber content of the feed. So basically the body is equipped to account for the osmolarity of the tube feedings formula by diluting them with the digestive juices. So osmolarity can be managed in this way. Enteral nutrition can be tolerated at very high feeding rate, even when it's infused directly into the small intestine, but still sometime it may cause diarrhea. And hydrolyzed and elemental formulas are not consistently tolerated by the better than the standard formula, but it is sometimes it is better if the patient doesn't tolerate the standard feeds, and it has the patient has problem of diarrhea. And most formulas contain milk byproducts only and are suitable for lactose intolerance patient. And if the patient, the lastly, the soluble fiber, the patient, if you the patient is still having a problem with the diarrhea, you can add some soluble fibers which gelatinizes the stools and reduce the chances of getting diarrhea. There, you should rule out the GI disease, the other fecal infection problem, drug-induced diarrhea, and infection-induced diarrhea. So these things you need to check when you encounter a patient who has been started on enteral nutrition and the patient faces the problem of diarrhea. Now, lastly, we'll discuss briefly about the peripheral parenteral nutrition and central parenteral nutrition. So basically, the difference in this two kinds of nutrition in peripheral PPN or a CPN. In PPN, basically you give the feed through a peripheral vein, and in CPN, you need to have a central venous access to give CPN. The other difference is the PPN is easy to dislodge and difficult to maintain. Basically, it is used when the patient has to be given parenteral nutrition for less than 2 weeks. And it is in CPN, it is more durable and easier to maintain. And if the patient has to be given feeds for more than 2 weeks. The peripheral parenteral nutrition, these lines are prone to phlebitis, and extravasation is likely to happen. The osmolarity is basically less than 900 milliosmoles in peripheral parenteral nutrition, whereas in central peripheral nutrition, there is less likely to have phlebitis and extravasation. You can add dextrose, amino acids, and other electrolytes in this central nutrition. And it is better tolerated, and it has got better nutritional value when you compare peripheral parenteral nutrition as compared to central parenteral nutrition. And in of course in peripheral parenteral nutrition, if the high demand of the nutrients, and if the patient has got fluid restriction, then it is difficult to maintain through peripheral parenteral nutrition. Now, when do you switch from oral feeding? When do you switch from tube feeding to oral feeding after extubation? So, first thing is you need to talk to your doctor. When the doctor orders that okay, the patient is ready for oral feeding, you start. You yourself evaluate that it is safe, and you start slowly. You need to evaluate the swallowing ability of the patient, and it should be very gradual. From tube feeding, you need to, from a continuous feeding technique, you need to switch to cyclic or intermittent feeding method, which allows more time by eating through mouth and also helps to increase the appetite. And when the patient consume at least 75% of their caloric requirement, the tube feeding can be stopped, and it is the time to remove the rice tube. That's it. Thank you.
Thank you, Dr. Siddharth. It was a very brief, precise, and well-made presentation on this particular topic of enteral feeding and how to decide about the various tubes and how to how to guide. I think that is going to help the listeners on this particular topic. Are there any questions? If there are, then we can take the questions. So there is one question that is how to approach the feed intolerance and use of prokinetics.
Yeah. See, as I told you that this gastric residual volume, this is a very uh, uh, controversial thing in the recent times. So if you have you need to evaluate that the patient is at the risk of aspiration pneumonia, then if there is a considerable gastric residual volume, consistently the patient has more than 500 ml of gastric residual volume, then you need to uh, look at the factors which can cause, if there is any factor which is causing gastroparesis, like hypokalemia and things like that. Once you have ruled out all the things, you can definitely start with the prokinetic, and then after giving a prokinetic, you start refeeding the patient in a smaller amount, and then in this way you can handle the intolerance along with the using of prokinetics.
Okay, I hope this answers the queries. And there is one more question. What is the autophagy and its practical implications in the ICU?
Can you repeat the question, sir?
The autophagy's practical application in the ICU.
Sorry, sir. I've this is out of. I mean, this, if you want, you can answer. I mean, I have not gone through these topics.
I think this is more related to the underfeeding in the ICU and calorie restricted feeding, and that's a concept beyond this particular lecture. But
yeah, that is entirely a different topic.
So I don't. Okay. So feeding in, another question is, what about the feeding in prone position? So how to go about that?
Yeah, that is quite a big challenge in feeding in prone position. In recent times, when the patient, so many patients have been prone in COVID cases, it has been quite challenging. So the same thing, when you put a patient in a prone position, then you basically you put a Riles tube. You need to check everything before you prone the patient, and you need to be very before you prone the patient. And when you need when you switch the patient to from supine to prone position, you again do a check X-ray, because there is a time, there are chances to get the patient, the Riles tube can dislodge while putting the patient in the prone position. And it's a very labor intensive thing, proning a patient. And you start feeding in a lesser amount of feed, like you start with 50 ml too early, you aspirate these patients. In these patients, there are high chances of aspiration of the gastric contents in the oral cavity and in the lungs. So basically, you start with low volume, and you keep on checking with this the residual with the GRV, and you also check the position of the Riles tube in through the X-ray, that the tube has got dislodged in everyday basis. So this thing needs to be kept in the mind.
Yeah, rightly pointed out, and that's a very pertinent question in today's era where a lot of ARDS patients are being ventilated in prone position. So I hope it answers the queries, and I don't find any other questions. I think you elaborated on the topic very well, Dr. Siddharth. So there are no more questions, and I think we can wind up the session. It has been an very well, elaborated on this particular topic. So congratulations and thank you.
Thank you, sir.
Thank you, sir.
Thank you, Neil.